My name is Stuart Howard. I am a nurse practitioner student here at Youngstown State University, and I will be presenting a patient to my preceptor, and his name is Mr. J. Mr. J is a 42-year-old white male that came in today with a painful rash on his right cheek and on the inside of his mouth. His symptoms started about 2 days ago with tingling and burning sensations before the rash appeared. The rash appeared yesterday. The pain was gradually worsened. He rated it today at 6 out of 10. He describes it as small fluid-filled blisters with a red inflamed base. It is constant, it is localized to one side, and does not radiate. He denies fever, headache, vision changes, or ear pain. His past medical history includes hypertension, which is managed with lisinopril, 20 milligrams daily. He also takes a multivitamin daily and has no allergies. Socially, he is married with 2 children. He works from home. He's a computer programmer. He reports that his job is high stress. He denies tobacco, alcohol, and illegal drugs. His review of systems is positive for a facial rash and pain, is negative for fever, chills, is negative for respiratory, cardiac, gastrointestinal symptoms, no facial weakness, numbness, or vision changes. For the objective, his initial vital signs are all within normal limits. The patient appears well nourished and is in no acute distress. He is alert and oriented ×3. His skin, there is a vascular rash. It has an erythematous base localized on the right cheek and on the right mucosa inside of his mouth, and also on the roof of his mouth. The lesions are clustered and follow the maxillary branch of the trigeminal nerve. The rash does not cross the midline, so in his mouth it does not cross the midline, it's just on one side. There are no lesions on the nose or eye involvement noted. The oral mucosa on the right side shows similar vascular lesions. The tympanic membranes on both sides are intact bilaterally. The cardiovascular, respiratory, gastrointestinal are all within normal limits. The neurological, he has no facial droop, no sensory loss noted. His strength is 5 out of 5 in all extremities, and coordination and gait are all normal. For the assessment, this is a 42-year-old white male with hypertension presenting with 2-day history of painful vascular rash localized on the right cheek and the right oral mucosa, following a dermatomal pattern. The findings are consistent with herpes zoster shingles involving the trigeminal nerve. The differentials: the herpes zoster, which is most likely given the dermatomal unilateral vascular rash with the pain that preceded the actual rash. Herpes simplex virus type 1 is another differential. It is possible, but it is less likely. The lesions are typically smaller and not dermatomal. Normally they actually on both sides go around the mouth. Could be contact dermatitis for another differential, unlikely due to the pain and the vascular pattern. Typically the contact dermatitis is normally itchy. Another differential could be impetigo, which is less likely because impetigo typically presents with honey-colored crust rather than vesicles. So the diagnosis is shingles or herpes zoster. Diagnostics: this diagnosis is typically clinical because of the rash and the pain that preceded the rash, that this is actually the herpes zoster. If it's uncertain, then we could do a PCR for the varicella zoster virus. It could be ordered. We could also do a CBC and a CMP that could be considered before starting an antiviral. The treatment for this would be valcyclovir, 1 gram every 8 hours for 7 days. For pain, recommended would be ibuprofen, 400 to 600 milligrams every 6 hours is needed, and applying cool compresses for comfort. We could educate the patient by advising the patient to with no contact with immunocompromised individuals, pregnant women, or unvaccinated persons until all the lesions have crusted over. Also, I would educate the patient on hand hygiene, stress management, and getting adequate rest. I will instruct the patient to report any new vision changes or any rashes near the eye immediately so that they can be treated properly by the proper person. Follow up, I want to reassess the patient in 5 to 7 days to evaluate the healing, and I would also consider. I would tell the patient to consider getting the Shingles vaccination post-recovery to prevent any reoccurrence. So we will schedule this patient for a 1-week follow-up. This patient is okay to actually go home and manage this on their own. Thank you.